So I was talking about, we're talking about the cardiovascular monitoring and what are the instruments. Now, you will go in to surgery and you'll have a regular you have your stethoscope. But in surgery, they're going to be draped, and rather than having to like reach under the drape with your stethoscope and getting close to the sterile field, what's usually recommended is to use the esophageal stethoscope. So it's a clear plastic tube, and I'm going to show you a picture of it, but you can pass it in the esophagus. And then we have earpieces in the OR, and it's easy to make them. You can just take off the bell, the bottom part of a stethoscope, and then you hook that up to the tube, and you just move the tube in the esophagus till you can hear the heart the best. And then you can use that. It does have well, let me go to it real quick. It's easier to explain on the picture. So here's what the tubing looks like. And I usually have you measure it before you put it in. So you can lay it, and right about the point of their elbow is about the fourth to sixth rib space. And that's where the heart is. So, they're showing you on this picture, you can measure, and then about how far you have to put it. And all you do is this just passes in the esophagus. It's a blind, you don't have to look. It just should fall. I mean, it really shouldn't go in the trachea because you've got a tube in the trachea. So this should just slide in the esophagus blindly. And then you can hook it up to a stethoscope. Now they do make these audible monitors, and you can hook it up to this monitor, and then it'll play the heart sounds. It'll give you a beat for every heartbeat. I have not used one of these. We always just hooked it up, and then I would just hang the stethoscope on the table. Sometimes if I was really concerned about my patients, I'd even leave like one in and I'd take one out so I could like hear the doctors, or, and I could always hear the heartbeat. But, everybody, when the students get to use these in surgery, they're like, oh, that's really nice. I'm like, yeah. The only thing you have to worry, and, this is just a clinical tip, is if you have a big dog with a long neck, like say you had a big German Shepherd or a Great Dane, you won't always be able to put it this far, because you never, and this is just very important, you never want to put this all the way in the mouth. I always like the tip of this outside of the mouth, because I've had enough patients wake up super quick and they start chomping after surgery, and then you can't reach in there and grab it. So I always like to have a piece of it that I can grab and pull out. And even if you can't get it all the way to that point, you can still usually hear the heartbeat. It may not be as strong, but you never want to put an endotracheal tube all the way in the mouth. You never want to put these in the mouth, because again, when they wake up quick and they're chomping, it's almost impossible to try and hold their mouth open, and you don't want them to swallow this. And then you're doing another surgery to go fish out an esophageal stethoscope. But it's a good audible monitor. The other monitor you'll have an EKG, an electrocardiogram, and it is just a graphic representation of electrical activity of the heart. And the main reason to use an EKG is to detect any arrhythmias, any abnormal electrical activity. Now, I've already explained to you, like a sinus arrhythmia is not a dangerous arrhythmia. Sometimes first degree heart block, which is an arrhythmia, is just sometimes happens when they have a bradycardia. So I really, the thing that and I've kind of already told you this, is that when you get in and looking at a monitor and it gives you a heart rate, people have a tendency to want to write that number down. But there's a lot of electrical activity in the room, or sometimes there's vibrations on the table. Sometimes people hit the leads, they dry out. So sometimes that heart rate can be inaccurate. So you always want to go off of what you hear or what you feel by putting your hand. That's always going to be the most accurate. And remember, when you have electrical activity, we assume the heart is beating. Electrical activity is what initiates the atria and the ventricles to contract, and then they pump blood. But if you remember, we get into that disassociation, which I'll talk about. You know, here is the flow. This is what you're measuring. So let me get into it here. You've got your SA node, and then you've got, it connects to the AV node, atrioventricular node, which is between the atria and the ventricles. And then those fibers continue down into what they call the right and left bundle branches. They go through what's called the bundle of His. This is kind of where they're together, like in a bundle, and then they separate. So, and what the node does is when the SA node fires, the AV node is going to delay the impulse to allow the atria to contract. And then it's going to send the signal, and then the ventricles, because you don't want your heart squeezing at one time or blood would go nowhere. It has to, you know, be a coordinated atria contract, then ventricle, then the blood goes out. Now, you guys have already done this in Tech 4. You guys have done ECGs, so I'm not like completely trying to reteach that whole class, but the main thing as a technician is I want you, when you look at an EKG, the most important is, for every P wave, do I have a QRST? Now, cats tend to have a very, like what's called amplitude. They have a smaller amplitude. A dog has a bigger one. And then a horse, their heartbeat is much slower. So you're going to have a much slower ECG tracing. You know, cats will be rapid, dogs will be somewhere in between. And then sometimes horses will have this notch in their P wave, and then you've got a QRS and a T, but you see you have this big pause. But mainly as a tech, I'm looking at the ECG and I'm like, do I have a QRS for every P wave? You should have that. Is the shape normal? Is it a normal PQRST tracing? You know, it takes a lot of experience to get good with EKGs, and I by far still sometimes, you know, I'm like, I got to get somebody to double check it with me. You know, I mean, I can recognize the very common arrhythmias, and then a sinus arrhythmia, which again is normal. Well, really, dogs and horses and cattle, we don't typically see it in cats. Maybe a bigger cat like a Maine Coon, but in your average cat, the heartbeat is usually faster, and we don't tend to see this. So in a cat, it could be significant potentially, but it's coordinated with respiration. Some that we have to, and the other thing to look at is something, anytime when we talk about sinus, that is like a normal, if we say NSR, normal sinus rhythm, you can also have sinus bradycardia and sinus tachycardia. What that means is they have a normal PQRST complex, the rate is just slow. So it means it's a normal PQRST, but it's just a slow rate. But it can be, again, when they're bradycardic, is it from the drugs like dexdomitor? Are they too deep? Are they cold? All the reasons that I talked about bradycardia are reasons for sinus bradycardia. And the same thing is sinus tachycardia, is that's just a normal PQRST and it's just too fast. And again, are they getting light? Are they feeling pain? And then the way you treat that, it depends on the reason. You know, if they're light, you're going to deepen them up. Remember, if I said if they're hypotensive, you're going to turn them down and push fluids. You know, so there's different ways to treat these depending on what we think the reason is. And if you look at this, this is a normal sinus rhythm. And then we have a normal sinus rhythm in a cat. So this is just showing you dog ECG versus cat ECG. But again, a cat heart rate is much faster than a dog heart rate. But if you look, P, QRST, P, QRST, P, QR, you know, normal tracings. Sometimes in cats, it's sometimes harder to see, but you know, you can see that's one. You've got them labeled here. Now let's talk about some of the arrhythmias that are more severe. You can have what's called AV block. And what we usually break down AV block is first, second, third degree. And a first degree block, you have a PQRST, it's normal, except from the P to the R is longer. Let me show you on the picture. It's easier to show you. With this graph, it looks weird on my screen, but this P should be closer to this QRS complex. So you see how far away it is? So that's a delay. It's a delay in the conduction system. And again, this, just by looking at that, I'm like, this is a very low heart rate. This is very low. So this dog would probably get atropine. All three of these dogs would be treated with atropine, potentially turning them down, potentially reversing drugs, but sometimes they'll start with atropine. Now, in this ECG, you have PQRST, PQRST, and then you have a P with nothing. And then PQRST, PQRST. And so you're getting these occasional P waves by themselves. And this is a second degree block. This is actually, there's a note here that this is from a horse. That's not significant for the ECG, but you can see this is a slow heart rate. And then the bottom here is more severe. They say this is actually in a cat. You have a P, QRS, P, QRS. Now I have a P, P, P. You have some of these Ps that don't have QRS. And so when you have multiple Ps, that's a third degree. And again, these are Brady arrhythmias, can be induced from drugs, anesthetic depth, but typically they're either treated by drug reversal or atropine. One that you can see, and this one, I want you to know the different heart blocks for the test. You don't need to know this supraventricular premature complexes. This one isn't as common. Let me go to the supraventricular tachycardia. You can have multiple SPCs in a row. And what hopefully you can look on this ECG is they're showing you this is your QRS, but it's almost like your P is on top of your T. Because the rate is fast, it's kind of like they're overlapping. So, I'm not really seeing the P because the P is being obscured by the T. So it's probably somewhere in here. But again, this one, we do have drugs like atenolol that will slow the heart down. Sometimes also they're too light. So treating this one is a little more complex than just atropine. But this is a tachyarrhythmia. We're not going to want to do anything to speed up the heart. And we don't have a lot of drugs that slow the heart down. But this is definitely something to let the doctor know. And then you have your VPCs. Sometimes people call them PVCs, VPC. And the thing about these is obviously this is wide and bizarre. And you have a PQRST, and then you have this thing that goes, and then we have a PQRST, and you can get runs of them intermixed with normal beats. And the problem with this is that the ventricle is contracting separate from the atria. And normally, they're not going to generate a pulse. Like, okay, if you did not have an EKG, and if you were listening to this dog's heart or feeling a pulse, you would feel a pulse here, nothing, pulse, nothing, pulse, 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 nothing. So you're getting these pauses where you don't expect them. And that's what happens is that, because think about this way, the ventricle needs blood from the atria to pump out blood, right? So if the ventricle contracts before the atria, how is it going to get blood? So when it pumps, it's not pumping anything out. And what's happening is you're not necessarily feeling a pulse. And so they're dropping pulses. And it's different, okay? Also, if your ventricle contracts before your atria and you don't hear that beat, it's because the ventricle, when you hear a heartbeat, it's the valve opening, but if the atria didn't contract, the valve doesn't open. So you see where you're lacking the sound and you're lacking the pulse. Again, sometimes I will tell you, under anesthesia, I have had animals that have had occasional VPCs. like they throw one every 2 minutes. We usually count. So usually on an ECG, if I see one, I look at my watch and I start counting. How many do I see in 1 minute? And sometimes I can have one and I could go 2, 3 minutes. Sometimes I have them once a minute. And a lot of times, unless the blood pressure is awful, the color is bad, the doctors will say like, well, they're just occasional. If they're having runs of them and my blood pressure is suffering, my dog's color is suffering, then sometimes we will treat them. We usually treat them with lidocaine. And again, that's the doctor's call. So that would be a little bit different. Okay. And then ventricular tachycardia, if you see runs of this, then obviously sometimes they'll throw a big run and then they'll have a bunch of normal PQRSTs. Usually these would be treated if we're having runs and runs. Sometimes this is seen in animals that have splenectomies. For you guys that are working, and I know Ireland, you're at the emergency practice, and I don't know if you've done any splenectomies. Sometimes these patients are on EKGs for like a day or two after surgery. So I don't know if, we do these on emergency. And for some reason, there's a connection to the spleen being removed and a chemical being released. We tend to see this with splenectomies. So sometimes splenectomy patients, well, like I said, sometimes we'll have them hospitalized 2 or 3 days running continuous ECGs while they're, being recovered. Okay, there are a couple different fibrillations, and I know you guys, yep, so yeah, in foreign bodies, oh, you guys all work there. I had no idea. All 3 of you work there? Oh, that's wild. And when you guys don't hospitalize overnight, do you? Are you open overnight? Sometimes. Well, because a patient like that, if a patient's having runs like that, like say you guys did the surgery, that dog would need to be on continuous ECG. So either somebody would have to stay and monitor it, or maybe, I know sometimes you guys send cases over to VCA, but that dog needs to be on a continuous ECG, blood pressure measurement, checking blood, things like that. So yeah. Well, interesting. Okay. Well, I didn't know you guys, wow, that's cool. Okay, let me talk about the different types of fibrillation, because I know a lot of you guys watch the, you watch Grey's Anatomy, or, you hear VFib or whatever. There's atrial fibrillation and ventricular fibrillation. Now, atrial fibrillation, these animals are sometimes walking around normal, acting fine, maybe an occasional cough. You hook them up to an ECG, but what you tend to see, and it's hard, this is not a great one, is they get an undulating baseline. It means, so, the baseline is the flat line in between the PQRS. Let me go back. So this is your baseline. In between the PQRS your line, and that should be nice and straight and flat in between each beat. If there starts to be like, it looks like a vibration, that's where we tend to see atrial fibrillation. Sometimes you get an absence of the P wave. Sometimes the problem is you can't see the P wave because of the vibration. So you get a normal QRS. This is generally a tachyarrhythmia. I picked this up. We had a radiation patient. It was a big old Italian Mastiff, and I hooked up his ECG, and it was fairly fast. His heart rate was around 140. This dog was like 150 pounds. He was huge. And I was like, okay, his heart rate's fast. I was given fluids, and then I see this vibration in the baseline. And at first I thought interference or vibration, maybe from the radiation machine. So I wet the leads really good. Like I re-put the leads all on. I put more alcohol. I even went and got a little ECG gel or some gel from the ultrasound. And it didn't go away, because sometimes you'll get vibration if your leads are dry, or, sometimes when you put alcohol on, that's going to dry out. Sometimes you have to put more alcohol, especially if the procedure is long. But when you put this on, sometimes by re-wetting them, it goes away. But in my patient, I re-wet the leads, I repositioned the leads, and I got the same pattern. And again, we were potentially going to do a cardiac workup, but the dog was older, it was getting radiation, and the owner declined. I mean, he ended up doing fine during anesthesia. Now, this is the bad one. VFib, this is seen in cardiac arrest, and there are no QRS. You get this. There's now fine and coarse. But anytime you see this, now this is when they typically get the paddles and go clear, because what this is disorganized electrical rhythm. It's a disorganized, and sometimes what you do by shocking them is you're trying to shock that electrical system back into function, into a normal rhythm. Now, if you do not have a defibrillator, some clinics obviously, don't have it. Sometimes you can smack their chest, like thunk them. It's called a pericardial thunk or thump. And sometimes that will get the heart back in. I mean, obviously this dog's going to get like epi, atropine, lidocaine, and that definitely is not a good thing. And obviously it's not on here, but if you have a flat line, that is asystole. So there is a difference between a flat line, which means there's no electrical activity. With fibrillation, there is still electrical activity. The heart's still kind of there. It's just unorganized. And that's why you're trying to get it back into an organized electrical rhythm. So I would argue, asystole, when you have just a flat, the beep, and it's like, which is super eerie, that's not good. So, and then the thing that I've talked to you guys about, which is called PEA, it's also called electrico-mechanical disassociation, or EMD. This is where you do not have a heart contraction, you do not have a pulse, but you have a normal ECG. And that can happen. This tends to be associated with like immediate cardiac arrest. And this is why it's critical that you guys don't just stare at the ECG, and don't just use your ECG. I did this at Purdue. We euthanized a dog during surgery on the table, owner's wishes, bad case. I gave the euthanasia solution. I had a bunch of students with me, and I had one girl just look down. I said, don't look at the EKG, raise your hand when you can't hear the heart. And everybody else in the room, I said, you watch the EKG. And when we gave the euthanasia, the dog's, probably about 30 seconds or so, she raised her hand. She couldn't hear a heartbeat. The ECG ran normal for 10 minutes, normal PQRST tracing, but the anesthetist had not lost, or had lost the heartbeat almost immediately. And this is that disassociation, electrical, mechanical. And my issue is, if that was a case and you were the anesthetist and you kept looking at your ECG and writing down your values, that dog was clinically dead for 10 minutes. And in dogs, unfortunately, we have about 5-10 minutes to resuscitate to be successful. It's not like people where you're like try and go for a long time. We got about 5-10 minutes. So that dog was dead for 10 minutes by the time the ECG went abnormal. So what I tell you, and sometimes people think I hate ECGs, I do not. If you think something is strange, you have to put in your stethoscope, and you should be listening the whole time anyway. And that's what I tell the surgery students. I said, don't write down that number from the ECG machine for your monitoring. I said, use your stethoscope. I said, that's going to be the most accurate, because you don't want, again, it's rare, but just knowing that it can happen, you don't want to miss something on your patient. Are there any questions about ECG rhythms, ECGs, monitoring that part of the heart? Just holler if there's something. Okay. So the other thing, we're still talking about circulation. Obviously, your capillary refill time, because your capillaries are, attached to your vessels. And this is, obviously you push how many seconds till it goes back to normal. Obviously, less than 2 is what we want. When you're starting to get to 2 seconds or greater, what does that mean? There's poor perfusion. It means it's taking too long for the blood to get into the capillary. Now, remember, I told you, if you remember from anatomy, because I just did my heart lecture for them, so it's all fresh. When the blood goes from the artery to an arterial to a capillary, that's where oxygen is exchanged. So for the tissues to get oxygen and for the tissues to give CO2 back, you have to have adequate circulation to the capillaries. And so if I have extended CRT, that means poor perfusion. Perfusion is oxygenated blood moving into the tissues and all the cells, and CO2 going the other way. So to maintain CO2 balance, oxygen balance, perfusion, we need good cardiovascular function. And obviously anesthesia alters cardiovascular, so we just want to make sure we're not altering it too much, to the point where it'd be detrimental. So the things that can cause a, extended CRT, if you start to see it. Now, an epinephrine release, epinephrine vasoconstricts small vessels. So did they have an epinephrine release, which could be from an allergic reaction? What I tend to look at under anesthesia the most is low blood pressure. So if your animal has a low blood pressure, like it's been falling and falling, the lower the blood pressure, the worse the perfusion potentially is going to affect. Obviously, too, we battle hypothermia. These animals in surgery are under longer, especially, if you're at a specialty hospital and you're doing surgery, those surgeries are longer. The longer they're under anesthesia, the colder they get. That affects the circulation to the capillaries. So you got to warm them up. Now, heart failure, there's not a lot of times we're doing anesthesia on animals in heart failure unless it's absolutely necessary. But does the animal have a cardiac condition? Did they come in the door with a pre-existing condition? But I also think about blood loss or shock. So unfortunately, sometimes when sometimes on emergency, one of the common things is sometimes a dog comes in with what's called a hemoabdomen, where their spleen may have ruptured. A lot of times dogs that get splenic tumors, and the spleen can grow a tumor, and the problem is the spleen is up under the rib cage. German Shepherds are renowned for this because they have a deep chest. The spleen is up under the ribs and a tumor's growing, but the problem is the tumor doesn't grow out of their side. It's growing, and the owner, it's not their fault. I mean, they're not going to know that there's a tumor. So sometimes what happens is it unfortunately ruptures. If I had a dime for every owner, and I've done a lot of splenectomies in my day, where the owner said, yesterday the dog was normal, playing in the yard, fetching, and then my dog collapsed today. And that is not an owner's fault. That's an awful disease. And what happens is these dogs come in and they're very pale, tachycardic, weak pulses, swollen belly. We do a tap, we pull out whole blood because it means they're bleeding out of their spleen. That dog has to go to surgery ASAP. I don't have time to stabilize them, and we don't want to give them a blood transfusion. Why? In the scenario I just explained to you, why am I not going to start with a blood transfusion? Any thoughts? If you have a dog actively bleeding into their abdomen, the problem is if I give them blood, where is that blood going?
It's just going to go straight to the abdomen because you have to fix the bleed before you can put more blood in.
Amen. Amen. I mean, you want to initially, this dog does need blood. The problem is if I give it, it's going to go right into the belly. So sometimes we got to rush to surgery, take out the spleen, clamp the vessels, then start the blood. Now, you guys in ClinMed 5, that's where you guys talk about critical care and all this stuff. There is something called an auto transfusion. I did a couple when I was at Purdue, but we can take the blood from the belly and give it back to them because it doesn't clot in the belly. So it's called an auto transfusion. Now, normally you just get blood products and you give a blood transfusion either from a donor or you can get packed reds. You can order blood. We keep blood on hand at BCA. But when I was at Purdue, we kept blood donors. We kept greyhounds in the hospital. We rescued them. They lived in the hospital for a certain amount of time, and then they would get adopted. But if we absolutely had to, we could call down to ICU and say, we need a blood transfusion now. You got to bleed one of the greyhounds. They'd get them out, pull the blood, give it to us in surgery. So there's different ways to do it. But if they have blood loss, they're going to go into shock. But the problem is, ideally, you would fix shock and blood loss before surgery, but sometimes you just have to get in there and start. And you can give them colloids and fluids till you can get the bleeding stopped, and then follow up with a blood transfusion. So that was a lot to explain about CRT, but I want you to think about the scenarios that we're in. The other thing, too, is that if you have a low temperature, if you're looking at, especially if they're hypothermic, a low temperature in that affected area is going to affect the CRT. So if they're very hypothermic, sometimes it's going to be hard to tell, is the perfusion really bad, or is the temperature just affecting the CRT? That's why you got to look at everything. And then one of the most important things to look at is blood pressure. And the blood pressure, again, from physiology, is the blood exerted on the arterial walls during left ventricular contraction. So we're not measuring the right side of the heart. The right side of the heart is pumping to the lungs. When we measure blood pressure, we're measuring blood pressure in systemic circulation, which is coming from the left side of the heart. And then it plumps out to the arteries. And when they put a cuff on you, when you go to the doctor, when we put a cuff on animals, it's occluding the arteries in the system, in the body, and it's going to get an estimation of what is the pressure in those arteries during circulation. And we're not measuring, venous, we're measuring arterial blood pressure. Now, when you put a cuff on a leg, there's veins there, but it's doing the measurement off of the arteries in that area. But this is how we evaluate tissue perfusion. Tissue perfusion is directly linked to blood. If you have good blood pressure, that you have enough pressure to push blood to every area of the body. So that's what you can assume. The things that we have to think about, and like I said, you guys had anatomy an age ago, but all this was in when I talked about what blood pressure was. Their heart rate, there's stroke volume. Stroke volume is the volume of blood being pushed out at the aorta during the ventricular contraction. So we have to have adequate stroke volume, which means your animal has to have adequate blood volume. The animal that was in shock, that lost blood, they don't have adequate volume. The heart can pump like crazy. It doesn't have anything to pump because the blood it's pumping is going out into the abdomen. So do you see why sometimes the heart will go really fast? The heart's like, guys, I'm trying. I'm pumping, but nothing's happening. Well, the problem is we got to get volume to the heart. So what is the blood volume? What is the compliance of your arteries, your vascular resistance? When an artery is a tube. And remember I talked about vasoconstriction is when it narrows, vasodilation is when it's open. Which vessel has more resistance? Vasoconstricted or vasodilated?
Constricted?
Yep. Because if it's constricted, there's resistance. So the problem is, like when we give dexdomitor, it causes vasoconstriction. So when the heart goes to pump, there's increased resistance. And then the heart slows down. There's more to that I'll get into. But yeah, so if there's less resistance during vasodilation. Now, Blood pressure will kind of ebb and flow. It will vary at times. The problem is when we're in surgery, you guys will do, um, you guys will do, um, what am I trying to say? When we're in surgery, you guys are doing a cuff. The cuff is going to inflate every 5 minutes, for example. So you're going to get an estimation every 5 minutes. If you had a catheter in the artery doing direct blood pressure, you would see the changes because there's just fine changes. Blood pressure will kind of change, and hopefully it stays about the same, but you get little bits of changes. Hypotension is when you have low pressure, and hypertension is when you have high tension pressure. So hypertension is high blood pressure, hypo is low. I most often battle hypotension. That's a common problem that I face because a lot of the anesthetics that we use cause vasodilation, which decreases resistance. But if a vessel's dilated, there's not as much pressure in it, okay? So when I give anesthetic drugs and they do this to the vessels, that's going to cause hypotension typically. The gas anesthetics that we use do that. So, when I go over drugs, I talk about the drugs that cause hypotension the most, because if I have an animal that's hypotensive before surgery, I may avoid those drugs. I kind of need to know which drugs I want to potentially use and not use. But anything, their heart rate does also play into it as well. But let me talk about the numbers is when you go to the doctor and they do your pressure, it'll say like 120/80 with a mean of 70. Okay. The top number, which is high, is your systolic pressure. And that's the pressure in your arteries when your heart is in systole or contraction. So when your heart beats and it pushes, it's going to create your systolic pressure. The diastolic pressure is the number underneath. So if you have 120/7, or what did I say, 120/80, I can't remember what I said. The lower number is your diastolic pressure. That's the pressure in your arteries when your heart is not beating or when your heart is in diastole. So I shouldn't have those numbers. Like, I don't think I've ever seen an animal that had like a 120/118. Do you see how close those numbers are? There's no reason there should be as close to as much pressure during diastole as there is in systole. The only time we had an animal that got too many fluids, it was fluid overloaded, and that added more fluid to the vessels. It increased the pressure in the vessels. So the diastolic number was really close to systole. But that's very rare. Those numbers should be pretty different. And then you have your mean. And your mean is the average through the cycle. Now, you don't add 120/80 and divide by 2. There is a different calculation. All I want you to know is the mean is the average through the cycle. This is your best perfusion indicator. And I think in surgery, Dr. Ritz only has you guys record the mean. There's a way to record all three numbers. When you do a blood pressure cuff, it gives you all three numbers. When we do a Doppler blood pressure, that only gives me the top number, which is the systolic. I think I put in I'm trying to think if I put it in your radiology notes. For the mean, you need to know it has to be above 60. 60 is my absolute. I don't want it to go below 60. And then my systolic number, I like to keep it above 100, usually upwards of 120. But I don't like my systolic below 100, and I don't like my mean below 60. That's starting to indicate that perfusion is being affected, and we maybe have to do something about it. Now, there is a note in horses, we don't like it to go below 70. Now, horses, it's very critical for their muscles after anesthesia. So horses get something called, it's called tying up. if they say a horse is tied up, it means what happens is, and it's an indicator of a lack of perfusion to the muscles. It sometimes happens after surgery due to poor positioning, like they didn't position, the horses have to be really padded. But sometimes it's a lack of adequate blood flow to the muscles and they get really tight and knotted. And sometimes after surgery, they might be limping, they might be kind of like dropping a leg. And sometimes you can feel them. And instead of there being nice, smooth muscles, you feel knotted, tight muscles. And it can get better, but perfusion it's critical for every patient, but definitely in the horses, you got to be cautious. So a mean, and again, what I told you guys for the mean, if it drops below 60, the body is starting to prioritize organs. When it starts going 60, 50, 40, if it's dropping, the body was going to prioritize brain, heart, lungs. And it's going to start taking blood away from other internal organs. The main one I'm concerned about is the kidney, because it takes a mean of at least 60 to maintain kidney perfusion. If it goes to 50, the blood is not going to be, maybe a very tiny amount is going to the kidney. But what happens is if you starve the kidney of blood, cells are going to begin to die. And kidney cells aren't going to regenerate. So I've talked to you guys, I think I've mentioned BUN before, your blood urea nitrogen. For an animal to have elevated BUN, to actually have kidney damage, 75% of the kidney has to be damaged before you see an elevated BUN. So my concern, especially when I've got older geriatric patients, they'll have a normal BUN going in, but say their kidney's hanging at like 60% is already destructed. They're older, their kidney cells have died. They could still have a normal BUN, but maybe and then they have crappy blood pressure. And then in 2-3 weeks, they come back in because their cat's like, they're peeing a lot, they're drinking a lot. All of a sudden we have an elevated BUN because now they have kidney damage. I mean, that's the real world consequence of having crappy blood pressure. Now, I don't want you to think every animal that has bad blood pressure is going to come out in renal failure. But what I'm saying is the reason that we take it so seriously is we need to maintain perfusion. Plus, that's how, if the kidney doesn't get blood, they don't make urine. If they don't make urine, they don't excrete waste. If they don't excrete wastes, where does it go? Where do the wastes go if they don't go out into the urine?
Back to the bloodstream?
Back to the blood. So then what happens is you have circulating toxins. It's setting up a whole cascade of events. So hopefully I've impressed upon you why blood pressure is so important, why monitoring. And I will say, when you guys get to working with these cuffs, and those of you guys that are working places now, what people tend to do in a clinic is they get a crappy blood pressure and they go, I don't trust the cuff. It's the cuff. It's the machine. And sometimes that's accurate. Mrs. Redmond's been battling the monitors and she laughs because they've all been working for me. And then when she goes in there, she's like, they're not working for me. I'm like, you have to talk really nice to them and go, I love you, monitor. I'm just kidding. But what I'm saying is, it's easy to go, oh, it's just not working. And sometimes we battle blood pressure cuffs and we do have problems, but it's just something to monitor. Maybe we have to watch that patient, maybe say, hey, why don't you come back in a month and we're going to just recheck some blood work. It might not hurt. Maybe we're going to push some extra fluids. So there's things we can do, but I'm going to stop there because I think we're going to, keep talking about this. Do you have any other questions?
Is our homework still going to be due tomorrow then, since we haven't finished the PowerPoint?